Thank you, Jan. Jan's done an absolutely amazing job of pulling together a huge meeting with countless talented, opinionated individuals, and she's turned it into a beautiful manuscript, which we're really excited to see published, which is going to happen very soon. So sometimes, you know, when you knock on the door and it doesn't open, and you knock on another door and it doesn't open, and then you knock on the third door, it doesn't open, you say to yourself, you know, I'm just going to figure this out myself. So our next speaker, Sayoni Lahiri, is a genetic counselor from UT Southwestern, and she has come up with a really interesting system to help identify Lynch syndrome patients in her community. And it's brilliant. So let's welcome Sayoni for her presentation.
I wanted to thank the organizers for letting me be part of the summit today. And I'll be talking about one of our population grants at the UT Southwestern Cancer Genetics Program called DUAL, which stands for Detecting Unaffected Individuals with Lynch Syndrome. I don't have any conflicts to disclose at this point. So we know that colorectal cancer has become a significant public health burden. On an annual basis, the United States spends about $14 billion on the treatment of colorectal cancer. And close to $4 billion of this is spent in Texas alone. Lynch syndrome is the most common or prevalent hereditary colorectal cancer syndrome, but also the most prevalent hereditary cancer syndrome that we know of. It accounts for about 3 to 5% of colorectal cancers that are diagnosed, but only 2 to 3% of individuals with Lynch syndrome have been identified. So we know that Lynch syndrome significantly increases one's lifetime risk for colorectal cancer as well as several other cancers. And this has prompted guidelines for risk management, which include earlier and more frequent colonoscopies. And studies have shown that compliance with these guidelines can reduce the risk for colorectal cancer by up to 60% and can also extend one's colorectal cancer-free lifespan by over 20 years. The reason that Lynch syndrome has been under-recognized comes down to a few different things. Historically, the testing criteria have been fairly strict and have focused on very striking family histories of colon, uterine, and other Lynch syndrome cancers. The testing strategies have focused on testing individuals that have been diagnosed with cancer versus testing those who are unaffected at this point in time. And oftentimes, Lynch syndrome is under-recognized by other medical providers. A large part of that comes down to the fact that these providers just don't have the time to get to the in-depth family history that we need to identify these patients. And patients themselves often inaccurately report their family histories. We know that in underserved populations, there are several other barriers that can often lead to people seeking medical care or prevent people from seeking medical care. This in turn leads to poor outcomes, such as later stages of diagnosis or higher mortality, which lead to higher treatment costs and a bigger financial burden on the families. And this, in combination with the previous barriers, can lead to a cyclical process for these patients and families in these underserved populations. So at this point in time, there are no large-scale programs in the United States to screen unaffected individuals for Lynch syndrome. But Lynch syndrome is prevalent enough, and there are strategies for risk reduction and cancer prevention to where there have been calls for population-level screening for Lynch syndrome. And I'm sorry, I'm trying to get through my slides as quickly as I can. So in 2016, the UT Southwestern Cancer Genetics Program received a grant through the Cancer Prevention and Research Institute of Texas, which is DUAL, to basically identify unaffected individuals who have Lynch syndrome. And so what we focus on is identifying these individuals through population-level screening through providing education via awareness campaigns and community outreach, and then identifying unaffected at-risk relatives of the patients that test positive. So the patients that we identify that are high risk for Lynch syndrome are navigated to genetics services, which include genetic counseling and genetic testing. And in order to address some of the barriers that I previously mentioned, we've focused on providing genetic services using different service delivery models, such as telephone-based counseling, at-home genetic testing. And then we provide follow-up for the patients that do test positive, not only for Lynch syndrome, but for other hereditary cancer syndromes that we've identified over the course of this program. Those patients are referred to various providers for follow-up care, and we do provide education to the patients and their providers. We have a genetic patient navigator who's able to help coordinate care, as well as cascade testing of unaffected relatives. And then we do go back and assess compliance for these patients. The goal of all of this boils down to cancer prevention. So coming back to the identification piece of this, what we've tried to do largely is engage in general population screening. And so we have implemented family history questions into the EMR at UT Southwestern, as well as the community hospital, Parkland Hospital. And we've also partnered with another CPRIT-funded program called C-SPAN, which provides fit kits to 23 counties in North Texas. And we've developed family history cards that are educational, but also meant to serve as a self-risk assessment tool. We've developed an educational website, and we've also partnered with various other programs, including 24-hour fitness, to increase awareness of Lynch syndrome. Like I mentioned, we've engaged in community outreach to provide education to patients as well as providers. And then we do follow up with cascade testing for at-risk relatives. We provide family letters. We improve access to our services through different service delivery models. And we do help cover the cost of testing through grant funding for these relatives. As you can tell from previous talks today, the battle to implement these family history questions into the EMR has been a long and uphill battle and continues to be so. So what we've tried to do through Dual is address several of the barriers that I had mentioned, especially in the underserved population. We've tried to expand our reach in Texas by partnering with C-SPAN. We've used navigation, telecounseling, and at-home saliva kits to improve access to several patients. We've partnered with the safety net hospitals in our community, and we use grant funding to cover the cost of testing for patients that are uninsured or underinsured. And we've tried to improve education and awareness of Lynch syndrome overall through various means. The testing that we perform through the grant can look at up to 47 genes that are associated with various hereditary cancers. And like I mentioned, we send saliva kits home to the patients that we counsel so that they can have the testing done in the comfort of their own homes on their own time. So over the last 30 months, we've actually reached patients from 59 counties throughout Texas. During the course of our 6-month partnership with 24-Hour Fitness, we've made over 12 million impressions via digital signage and marketing efforts. We've provided indirect education to over 280,000 people, as well as over 1,500 providers. And we have provided direct education to over 900 people and over 1,300 providers in our community. And of note, of our patient population, 60% of our patients are underserved. So over the last 30 months, we've screened over 127,000 individuals through our various clinics. Most of our patients have come from the mammogram clinics at UT Southwestern and Parkland. Of those, about 4.6% screened high risk for Lynch syndrome. And so far, we've seen close to 1,000 patients for genetic counseling, of which about 88% elected to proceed with genetic testing. And to break down that category a little bit further, so 8 patients have canceled their test after sending in a sample. About 96 patients have not turned in a sample for test completion. We're still waiting on results for about 134 patients, and we have results available for the rest. So within that category where we have results available, about 12% have, well, I'm not sure why it shows up that way, but about 12% have tested positive for a hereditary cancer syndrome. And we've seen about a 33% rate for variants of uncertain significance. So of the patients that have tested positive, 40% of those patients were found to have a mutation associated with Lynch syndrome, including 2 patients that had double mutations. An additional 29% tested positive for mutations in other genes associated with hereditary colorectal cancer, including a patient that, again, had double mutations. And then 31% of the patients that tested positive tested positive for a mutation in a gene not typically associated with colorectal cancer. And coming back to our Lynch group right there, over half of those patients were unaffected by colorectal cancer when they were found to have Lynch syndrome. So that is the group where we can make the biggest impact in terms of cancer prevention. So right now, some of our challenges that we're facing are a no-show rate of about 32%, a test incomplete rate of 11%, and a lower cascade testing rate than what we had initially anticipated. So those are things that we continue to work on. And like I said, it's been an uphill battle working with the EMR, so we continue to work on automating that process. And we are also working on providing automated messaging for colonoscopy recommendations to our high-risk cohort through this program. And I wanted to thank our genetics team at UT Southwestern for all the hard work that they do as part of Dual. Thank you.